I think Dane told me you were presenting today too.
Yes, Dana and I.
Awesome.
But you can hear me okay?
Yeah, I can hear you good.
Great. Thank you.
If you just want to make sure that you can share your screen and everything.
Okay. I think Dana's going to share his
Okay.
when he joins.
Yeah.
Um,
I'm watching the waiting room. I haven't seen him pop up
okay.
yet.
All right. But if not, I mean, I'm happy to share. Let me see if make sure I can. Mm,
And then anyone else joining you today?
no, just us.
Okay, sweet.
Let's see. Okay, can you see that?
Yep. Yeah, looks good.
Okay, great.
I don't know if we've formally met yet, but I'm Evan Isaacs. I'm a data analyst with the VNPC.
Yeah, we not formally, but have met. But nice to formally meet you. I'm
Yeah,
the community health epi program manager at in Dane's division. Um,
awesome.
but do a lot of work with our maternal health data and our specifically our pregnancy risk assessment monitoring system.
Oh, cool. Yeah, awesome.
Yeah.
Is Jennifer McDonald, is she introducing you?
Yes, she is.
I see her. I'll go ahead and let her in.
Okay. I'll also turn my camera on.
Mhm. Stay. Hi, Dane.
Hi, Dane. Hi, Jen.
Hi. I keep having to re-register every time. I don't know if that's just a me thing. I don't
I
know
don't know. I
why.
think I think I've heard that from other people. Um, I'll have to look into that. We just lost our communications manager, so
I saw that I have her on LinkedIn and yeah. Um, but yeah, anyway, I'm here, so.
sweet.
Dana, I share the slides, so when you're going, I'll just advance them for you.
Thank you.
Yeah, and I'll just go ahead and let everyone in at noon, and then we can just wait a couple more minutes. Usually by like 12:05 or so, there's a lot of people.
I could not unmute myself or start my video because I didn't see that I had to say yes to be recorded.
Oops.
But I have my little introduction for you all. So
Perfect. All right, I'll let everyone in.
Evan, do you want me to wait a minute or two before getting started, or someone else going to speak before myself?
Yeah, I think we can just wait like another minute or two as people still trickle in, and then I'll let you kick it off.
Okay. Okay, do you think we should get started, Evan?
Yeah, I think we're good.
Okay. Hi, everybody. Good afternoon. My name is Jennifer McDonald, and I'm the Director of the Division of Child and Family Health here under the Office of Family Health Services at the Virginia Department of Health. And I am here to introduce Dr. Dane De Silva and Dr. Kenesha Smith-Barber as your presenters today. We will be presenting on maternal child health data. And so the Division of Population Health Data is our sibling division, and it's one of the 4 divisions in the Office of Family Health Services. And the Division of Population Health Data provides epidemiological and evaluation support to the other divisions in our office. And so the mission of the division is to use the information or data to monitor conditions that aren't contagious, non-communicable, and are important to public health. And so the information collected also assists with improving programs and making recommendations related to policies. And the staff serve as technical experts in collecting this type of information, and they study the information and work to understand it. So their staff also supports very vitally the state and community health assessments and improvement plans. So I'll introduce Dr. Dane De Silva. He is the Director of the Division of Population Health Data, where he supervises the epidemiologists and evaluators across a variety of non-infectious disease programs. He and his team provide consultation on all epidemiological and evaluation efforts related to the programs in our office. He's an experienced population health researcher rooted in the life course and reproductive justice frameworks, and his research spans from the intersection of social determinants of health with birth outcomes, reproductive health, and infant and child health. He's passionate about using data in innovative ways to answer research questions, you'll soon find out, and that will inspire and inform programs and policies to support the MCH population. He earned his Master's of Public Health with a focus in maternal child health perinatal epidemiology from the University of British Columbia, and his doctoral degree in maternal and child health from the University of Maryland. I will also go ahead and introduce Dr. Kenesha Smith-Barber as well, so that they can have the rest of the time to present. Dr. Kenesha Smith-Barber is the Community Health Epidemiology Program Manager and the primary investigator for the Pregnancy Risk Assessment Monitoring System, aka PRAMS, here at the Department of Health. She leads a team of coordinators and epidemiologists who conduct and analyze population-based data in Virginia and works with community health and maternal child health partners and researchers researchers to study maternal and infant health outcomes, non-communicable diseases, and areas of improvement in community health. Dr. Barber is skilled in data analysis, program planning, coordination, grant and manuscript writing, and partner engagement, and her work aims to reduce disparities and improve maternal and child health outcomes in the state. She holds an MPH and PhD from the University of North Carolina, Charlotte, with a concentration in MCH epidemiology. In addition, she holds the role of adjunct faculty at BCU School of Social Work, where she faces one of her biggest professional challenges, making evidence-based statistics digestible and interesting for undergrad students. So please let me pop it over to Dr. De Silva.
Thanks, Jen, and thanks VNPC and VHHA for kind of convening this webinar and showcasing kind of our different agencies and in the data that we have for maternal and child health, and how we use that information. And so here with me, as Jen introduced, as well as Dr. Kenesha Smith Barber, and so we'll be co-presenting this presentation. All right. So just to kind of provide a kind of a visual of the structure of our Office of Family Health Services, as Jen had described, with our 4 different divisions. So this is just one arm, of course, of several different offices and programs in the Department of Health. But here we have, through our State Health Commissioner, Dr. Karen Shelton, through the Population Health and Preparedness Deputy Commissioner, who's acting currently right now, and to our office director, Dr. Vanessa Walker-Harris. And then, as you see here, the 4 divisions within our office that span a lot of our maternal and child health or family, kind of across the life course. Which is, Jen's division in DCFH, and then we have the population health data with our EPIs and evaluators, and then we have the prevention and health promotion, which touches on a large kind of range of the lifespan around chronic disease and substance use and injury violence prevention. And then, of course, we have our community nutrition division, which houses our WIC program, and our CACFP food assistance program as well. Next slide. So kind of looking a little closely in our division, again, to provide the context of what we do here in this division. So the division houses, and I realize I did not number these correctly, but we do have 5 different units here for across our division. So we have our maternal and child health EPI and evaluation unit. This unit provides a lot of support to our Title V maternal and child health block grant, which is our federal block grant through HRSA, which all states receive to support maternal and child health programming. And we also support program evaluation to a lot of our MCH programs, including Healthy Start and our maternal infant early childhood home visiting program, just to name a few. So this is kind of the unit that is responsible for a lot of, data and support for EPI and evaluation in MCH. And then we also have our community health EPI and surveys unit, which Dr. Kenesha Smith Barber oversees here. She'll go into it in a little more detail in the next slide, but largely contains the health surveys, community health EPI support. And then we do have our Virginia Cancer Registry. This is a statewide registry and is mandated to report cases of cancer in the Commonwealth. And they do a lot of data linkage as well with our death certificate and inter exchange with border states as well. And then we have our prevention and health promotion EPI unit, which provides support to one of the other divisions in the office, again, around chronic disease, injury violence, substance use, and tobacco control. And then lastly, which is a newer program, is our environmental public health tracking. This is a very interdisciplinary project that is that intersection between environmental health and chronic disease, and having that data available to folks to be able to health in some fashion. So it's all really important to identify or to acknowledge that. But I will focus more on kind of what the maternal and child health EPI unit and our surveys unit has to offer in terms of maternal and child health data.
Okay, and then just a little bit of a deeper dive into my position as the Community Health Improvement EPI Manager. So our team consists of both population health surveys and community health EPI. Our population health surveys are our PRAMs, which is a survey of mothers who just gave birth, our behavioral risk factor surveillance system for adults over 18, and our Virginia Youth Survey for middle and high schoolers, as well as Profiles, which is a survey of health educators and principals. So this team conducts survey coordination. We fulfill any data requests for this data. We do data visualizations like dashboards for our website and find ways to disseminate our data. And then we have the community health EPI team, and we support our local health districts a lot with their community health assessments and improvement plans, but it's not just that. Any non-communicable disease data projects that they are doing, we are here to assist them with. So we have a coordinator, a Northwest, Southwest EPI coordinator, and then a Northern Eastern coordinator. And as a team, we support the Central region of Virginia. So we provide training and mentorship to those community health EPIs, also assist with any data requests and analyses or dissemination, and data coordination specifically for our state health assessment and improvement plans.
So in terms of kind of an overview of available MCH data, of course, our role here in the division is to, look at our trends present in some really important data sources that are used at the national level and also feed into our Title V Maternal and Child Health Block Grant, and as well just in general to inform a lot of our programs and local health districts as well in MCH programming. And so, we use the data and find the data in different forms. Of course, we have direct access into our own internal data warehouse, which contains a lot of our vital records data and our hospitalization data. And then we also, aggregate and summarize the data into external dashboards and even other data products and reports. And then we also have, smaller programmatic data available that is on our website as well. And of course, we use publicly available data as well through other funders and other organizations that might have data tools and things like that available through federal partners and organizations that analyze and process large data sets. But for the focus of this presentation, we will focus on maternal health data, particularly in our division. I know we will also have our colleagues from the Office of Chief Medical Examiner in a couple of months that will present on data on maternal mortality. But for this purpose, we will kind of focus more on kind of our division and the data sources that we have. So kind of just a brief overview, we'll go through some of our vital records data. We'll talk through birth and mortality data. Then we'll kind of talk how we examine morbidity data. We'll then also go over our health surveys as well that are available to help inform maternal health, and then some other data sources, other sources that are available on our website that could be helpful. And we'll just go through each of these and talk through kind of what a description of these data sources, the frequency available, what we use that data for in terms of specific indicators, and then kind of strengths and limitations around it. So to start, we'll go through our vital records data, which houses our birth and mortality data. So in terms of data collection, this comes from our birth certificate data, fetal death certificate data, and death certificate data as well. And that fetal death certificate data, is around stillbirths and even some miscarriage as well. Virginia is one of the few states that doesn't have a specific definition restriction in terms of reporting fetal deaths, unlike other states that might have a gestational age cutoff or a birth weight cutoff. So it's really nice in that Virginia is able to even have information around miscarriage as well, which isn't often talked about, especially in when we think about pregnancy loss and how that is important to families, and we even have programs here, small programs around pregnancy loss, but definitely wanted to call that out, that's unique in Virginia, in that Virginia doesn't have as stringent of a definition, so we can kind of get at some miscarriage data. Of course, still there is opportunity or there is the possibility of underreporting, but still wanted to just highlight that. In terms of go back. In terms of the frequency and years available, so this is available on an annual basis. Our team currently has access, direct access through back through 2014, although there is opportunity to go even prior to that. However, we have to go through our vital records office to get that access, but we do have direct access to our 2014 to 2022. 2023 data are preliminary currently, and there's usually about a lag, about a 9-month lag before the prior year data is complete. So we usually expect around the fall for the prior year data to be complete, and that's because of out-of-state events that occur to residents here in Virginia. And so it takes time to coordinate with other states and get that information from other states who might have recorded a birth event or a death event to residents in Virginia. And I will mention too that kind of if we wanted to go to more historical data, that there would be caution in terms of comparability, because the birth certificate underwent a revision back in 2003, and this was implemented at different times throughout the country. And so there were some early adopters of the revised birth certificate, but Virginia actually didn't adopt the revised version until 2012, I believe. So, there were some new variables that were added to this revised version, which does make comparing kind of historical data a little more difficult. So, yeah, just wanted to call that out. But in terms of the indicators and what we use the information for, so birth certificate data, we definitely use that to look at teen pregnancies, also birth outcomes like preterm birth or low birth weight. There's also, some maternal health behaviors such as smoking, and there's a limited amount of also like severe morbidities that may have occurred, delivery type, whether the infant was admitted to the NICU, and so forth. So that's kind of just a snapshot of what we use the birth certificate data for. And then, of course, the death certificate and fetal death certificate, we can look at fetal mortality, so like that stillbirths, infant mortality or the deaths up to 1 year, child mortality, and maternal mortality. But I will just mention that for the definitions for maternal mortality here are different than what the Office of Chief Medical Examiner looks at, because they look at a more comprehensive picture up to 1 year. So I won't focus too much on maternal mortality here, but we can look at it up to the 42-day postpartum period. And that's more in line with like the international definitions that the WHO has set for more international comparability, but that does not necessarily tell the whole picture. So just wanted to call that out. In terms of the strengths and limitations for our vital records, the strengths is that, of course, this is a generalizable, it's a census of all births and deaths that occur in the state, and helps to provide those prevalence calculations, and in terms of the rates. We can drill down to census tract for our birth certificate as well. So we can drill down to, and death certificate, we can drill down to that. But in terms of limitations, it is just a snapshot in time. Of course, it's not a comprehensive list of variables, and there are some variables too with quality concerns depending on how they are collected. And also we just don't know about the timing of certain variables, whether an event kind of happened prior to an outcome being looked at. For example, while the birth certificate might indicate whether the mom participated in WIC, we just don't know what timing in the pregnancy they may have participated, and when that might have occurred during their pregnancy. So it is just a snapshot. Next slide. So we do have a dashboard that was just recently launched as of yesterday, and there is a link here. I will provide that in the chat kind of after this, but it does contain data from 2015 to 2022. And so the data indicators include total births and select outcomes like preterm births, low birth weight, late or no prenatal care, maternal smoking, Medicaid births. And then we also do have infant death counts and infant mortality. And as well, we have teen pregnancy. And some population counts. And we expect to update this annually with prior year data around December. So once that it's finalized in the fall, we'll be able to clean it and prepare it for an updated release at the end of the year. And the next page, and thanks Evan for putting that in the chat. The next slide shows kind of just a snapshot of this dashboard. So we have kind of a snapshot in the top half of the dashboard that kind of gives you a look at the counts in population, births, pregnancies, and some trends over time as well for the indicators that I have mentioned. And again, we can also stratify some of these by geography, including locality, health district, or health region. And then we also have stratifications by race and ethnicity, currently in 5 categories, but with some changes coming down federally related to how populations are categorized. We will have an option for a multiracial category at some point in the future. So just wanted to call that out. And we do have the geographic map as well, which looks at our indicators on kind of a quintile format. So the higher the quintile, it indicates a more worse outcome. So you can kind of take a look and see at where specific areas of the Commonwealth might have a specific indicator. All right, so moving on to morbidity data. So we use our hospitalization data, and if you can go to the next slide, our inpatient hospitalization data. I know Evan and Andre from VHHA also talked about this as one of their sources a couple months ago. If you were if you had attended that webinar as well. But we also receive that inpatient hospitalization data as well to look at a lot of the hospitalization and morbidities that might occur when someone is admitted to a hospital. So in terms of collection, it does contain inpatient discharge data from all Virginia licensed hospitals. And this is available on a quarterly basis, and we do have about a 9 to 12 month lag. I know that the VHHA and the VNPC through their dashboard that they had mentioned has a little more timelier data. We just go through a little slower process and cleaning and summarizing for our purposes. But we have a full year up to 2022 data, but we do have the first 2 quarters of 2023 available. So but when we do release data products, we usually tend to go up to a full year of data. And in terms of the indicators that we use this for, just to select a few to call out here for the maternal population, we definitely use this to look at our trends of severe maternal morbidity, which is a collection of 21 different indicators and largely kind of those end organ outcomes. So thinking of those end organ failures, acute myocardial infarction, eclampsia, really kind of these severe outcomes that do have or provide a high risk to mortality as well. Now, of course, there is this definition is available through the CDC, and that's the definition we use to calculate our severe maternal morbidity, but there are discussions underway about potentially expanding that and realizing that maybe the definitions are not perhaps comprehensive. For example, while eclampsia may be included, I know preeclampsia is not, and there is a lot of morbidity around preeclampsia and things like that as well. So there are discussions underway among like the maternal and child health sphere to perhaps update and maybe relook at that definition. We also use hospitalization data to look at maternal opioid use disorder and neonatal abstinence syndrome. So, as we know, there is a large, mental health and substance use a focus as well. So it is one of our main sources to look at for maternal opioid use, that might have happened at the time of delivery, and then any withdrawal symptoms in the neonate. But in terms of our strengths and limitations, we can use both ICD-9 and 10 codes to look at diagnoses that may have occurred upon discharge. And again, it is nearly all acute care hospitals, except those federal centers. But in terms of limitations, we are limited to inpatient, so we don't know what happens to the population with, more detail in like the emergency that might be treated and released. We do have some systems in place, but it's not necessarily in the same kind of structure as the inpatient hospitalization data. The other limitation too is that it's not linked or longitudinal, so we can't link currently serial hospitalizations that might occur to a single person, or link that to, for example, the baby. So right now we can look at a delivery hospitalization where the mom came in to deliver, whether it's a live birth or a stillbirth. And then we also have a birth hospitalization for the newborn specifically, but currently we don't have a mechanism right now to link those two, but we are working on it since that is an important feature to have. And so that's why when we calculate rates, we look at rates per hospitalizations. And I will say that the county level may not be as accurate because the county of residence is assigned based on the zip code, and we know that zip code crosses counties. So we do caution in terms of interpretation if you receive information at the county and locality level. So there's a potential for one locality to be underreported while a surrounding locality might be overreported or vice versa. So just wanted to caution that. And the next slide just shows kind of our examples here for the indicators here. We don't currently have any other than neonatal abstinence syndrome, which is a dashboard available. From the maternal side, we're still working on what that might look like. Especially, I think it's relevant or, of importance and interest to look at severe maternal morbidity. And so this is just, the trends that we see over the past 5-6 years. And the severe maternal morbidities rates per 10,000 delivery hospitalizations. And then to the right, we see maternal opioid-related diagnoses per 1,000 delivery hospitalizations over the past several years. And we see it on a slight decline here for opioid-related diagnosis, but SMM is on an increase. And in terms of to the question in the chat for is hospital data available somewhere to view, as mentioned, we do have a neonatal abstinence syndrome, but I know that the VNPC and VHHA presented as well a dashboard that's available to hospital systems as well that has this hospital data as well. All right, and then I'll turn it over to Dr. Smith-Barber to talk through our health surveys and other sources.
Thanks, Zane. So I'm going to be talking through our health surveys. First up is our pregnancy risk assessment monitoring system. This is a survey of postpartum people 2 to 6 months after they've given birth. They can respond either by mail, by web, and if they don't respond in either of those ways, they're followed up with a phone call. We use our birth certificate as a sampling frame. So each month we pull close to 200 moms or more from our birth files that from vital records, as Dean talked about. And then we end up with we're sampling about 2,000 moms a year and hope to reach a 50% response rate threshold each year. We also have the postpartum assessment of health survey for the 2020 birth year. And this is a follow-up to the PRAM survey. So with the PRAM survey, mothers get a postcard that says, would you like to be followed up for, a survey 12 to 14 months after the birth? And if they say yes, this is actually conducted through Columbia University, and they will give a survey which has similar indicators but a little bit different and takes place further down the line. And then pause, right now we only have 2020 data, but will take place again for our 2024 birth year. And we have PRAMS data all the way back to 2007 up through 2021. Generally, we get our data in the fall or winter of the next year, but CDC weights the data to be representative of all moms giving birth in Virginia, and they are behind in waiting. And so we're just any day now, we could be getting 2022 data, just not sure when. Some of the indicators that are included, there are multiple indicators. This is almost a 100-question survey, are unintended and missed time pregnancy, breastfeeding, initiation and duration, postpartum depression and screening, safe sleep, and dental health. And to answer the question I saw pop up in the chat, we do have an indicator for insurance type before, during, and after pregnancy. So you can look at indicators by that insurance. Some of our strengths is that it is generalizable to the state because CDC does the weighting process. And it helps us understand experiences before, during, and after pregnancy. So it gives us a little bit more of the story behind the birth in addition to what we have from vital records. Our limitations are we're not able to drill down really to districts or localities except for Richmond City Health District and Blue Ridge Health District. That is because we oversample those two specific districts, so we have that data. Our team is working to do synthetic estimates for the health district level data. And then CDC has told us they're working on small area estimates for certain indicators. And we actually do have some already for breastfeeding and safe sleep on our website. So here's a view of our website. On the left, you can see our PRAMS data tab has tables of commonly requested indicators and then select topics by demographics. There are also some fact sheets and infographics, and then our annual surveillance data here, which has some of our most commonly requested indicators by year. You can see that those are available by race and by those 2 health districts, again, that we oversample. And then to the right are our dashboards. Right now, we just have unintended pregnancy and breastfeeding that's available. You can see it's broken down by race. There's that insurance coverage, marital status, and other social determinants. We do hope to add additional dashboards within the year, so stay tuned. Next up is our behavioral risk factor surveillance system, which is not a survey of mothers, but can include mothers. This is a telephone survey of adults over age 18 or 18 and older, and it's otherwise known as our Virginia Adult Health Survey. And it collects state data regarding health-related risk behaviors, chronic health conditions, and use of preventative services. And like PRAMS, it provides weighted prevalence estimates. In Virginia, we aim to collect about 8,000 completes each year in order to be able to provide the health district level information, but it is available at that level. This is also annual, and we do have this data through 2022. Something to note about this data is it includes some modules. So in addition to the survey, they may have modules on specific topics. And one of those is our family planning module, which I'll go over a little bit more in the next slide. We also have indicators for healthcare access, demographics, including pregnancy status. So we can pull out what if people were pregnant, that specific subset, and then look at indicators by that pregnancy status. Also oral health, tobacco use, and alcohol consumption. The strengths, again, this is generalizable to the state, and BRFIS already has small area estimates that are available. The limitations are not all questions are asked every year in every state. So leads to issues with when you're trying to trend the data and also when you're trying to compare to other states or at the national level, because not every state may ask every question that's available. Going back to the demographics, just and the indicators, we have also marital status and income. We also have some screenings available. So it looks at mammograms, pap tests, HIV testing, and then for healthcare access, healthcare coverage, doctor and medication being inaccessible due to cost, routine checkups in the past year, and then whether they have a personal doctor or a healthcare provider. So some of the general BRFIS data, it's not by maternal or by pregnancy status, but it is available on our VDH data portal in our health behavior portal is what it's called. This is soon to be updated because we're also getting a chronic disease dashboard. So I'm going to pull some of these indicators off and instead put some different BRFIS indicators. So more to come on that as well. And then a little bit more about our family planning module. This is a poster that our team presented at the AmChip conference last month. And they looked at our family planning module for BRFIS. So it started in 2017 and it's continued through 2024, but the only year that we didn't do it was 2018. Some of the questions include, did you or your partner do anything the last time you had sex to keep you from getting pregnant? What did you and your partner do to keep from getting pregnant? What was the main reason for not doing anything to keep from getting pregnant? And then in the last 12 months, when you saw a doctor or other healthcare provider, did you have a conversation about your desire to avoid pregnancy or become pregnant? And that question, people can answer as yes, they brought it up with their provider, or yes, my provider brought it up with me. And I just want to note that one of the findings from the study that the team did was that there is a higher percentage of client-initiated conversations compared to provider-initiated conversations. And then another main finding was that Hispanic women, women with less than high school educational attainment, were less likely to discuss family planning with their doctors and less likely to use any type of contraceptive method. Okay, so that was our surveys. We also have the Virginia Youth Survey, but I didn't bring that up since we're talking about maternal health data today. But that survey includes middle and high schoolers and ask about their health behaviors. All right, so currently our some of the dashboards and other available data include our Community Health Improvement Data Portal. You might have heard of it as the CARES portal, and you can find that on virginiawellbeing.com, but also this page has links which will be shared. And it's a health assessment tool, and it has over 100 indicators from national, state, and local sources like VDH, VHI, the vital statistics, the community surveys, and then CDC. It has a map room where you can do interactive mapping and have access to more than 30,000 mappable data layers. And we also have My Sidewalk, which is a data storytelling platform. And we're using that for the MCH needs assessment. And it's a community data library that contains publicly available data sources, including our ACS and census indicators. There is a NAS dashboard available, and as well as quarterly physician reported NAS cases. Then what's not mentioned here are some other federally available data sources, so including our March of Dimes maternity care desert reports, and then Title V and HRSA resources. In the future, we will have a division-wide web page that will be a hub for where all of these data will lie and gives more information about our teams. We'll have expanded PRAMS dashboards that will include more than unintended pregnancy and breastfeeding, so hoping to add new indicators there. As Dane mentioned, our environmental public health tracking team is fairly new, but they will have a dashboard upcoming. And then there will be an expansion of our infant mortality dashboard as well. So for requesting data, we do have a REDCap form, which will be provided in these slides. After you've looked at all the resources, you can submit a REDCap form to our division, and then the appropriate epidemiologist will reach out to you if they need more information about your data or with your finalized data. And generally that takes at least 2 weeks for them to pull. You can get the data at aggregate level, which is the most commonly provided one, but suppression rules may apply for smaller counts. Line level data is available for some of our sources, but that would require a data sharing agreement as well as IRB approval. So we're happy to take questions now, and here are some resources. We have the data request form here, where not only you can request maternal and child health data, but all of the other data that our division holds. We have a data feedback survey for once you've received the data. We'd love to get your feedback on how the process was. We have our links to the dashboards that we mentioned today, and Dane and my emails listed here. I don't.
But Kanisha, it does look like there is one question that I don't think was answered. I thought it had something to do with religious.
I think religious affiliation.
Yeah.
Oh, no.
I can't see that now.
I don't see that. But if that was the question, we don't have that information available in PRAMS, or I don't believe it's in Berphus either. The websites for both of them have the copies of the questionnaires, and usually I tend to do a Control F to find things if you're interested. So you can double check there, but I don't believe we have that. Dana, I don't know if you answered, is the hospital data available somewhere to view?
Yeah, I did mention that the only one from VDH side is currently an NAS dashboard, but I know that's through VNPC, VHHA through their dashboard for hospitals. Our members can access that hopefully I'm not misspeaking there so definitely please VNPC or VHHA chime in there. But from our side, you can definitely request information, but we don't currently have any visual dashboard yet.
Hey, Dane, it's Mary from VHHA Foundation. Thank you, first of all, for sharing all this excellent information, really well organized. So great work there. I believe Evan dropped the link to the previous data webinars because my subject matter expert is not on here. My partner in crime, Andre Toleris, who's our director of data analytics for VHHA. I don't want to miss any nuances, but you can access the recording of the session that Andre and Evan co-led, specifically about the hospital data dashboards. That includes information on how to request additional data, or what the VNPC can provide in terms of de-identified and aggregated data. So thanks.
So Dane and Kenesha, thank you so much. If there's no other questions, I think we may be able to wrap it up. And I believe the next webinar in this series is in June. And Mary, please help me out with dates that I don't know it at the top of my head. Or anybody.
Hey, it's going to be the second Tuesday in June, and I believe Virginia Health Information, so our Health Information Exchange, VHI, is going to present. And it'll be at the same time. Join us for lunch. We'd be happy to have you.
Thank you to everybody who's joined. Thank you, Dane and Kenesha. Appreciate it very much.
Thank you. And again, feel free to reach out with any questions or data requests.
Thank you, everyone.